Hey guys, Nick here, and I'm presenting my case for our case presentations. The case that I'm presenting today is a case that kind of surprised me by the way that it came in. It came in as a fall from standing, and the dispatch notes read something like, fall from standing, fell while doing laundry, patient has a history of falls. And at this point in my write-outs, we've had a fair amount of these, so as I'm sure you guys know, what you can expect is that this patient probably just needs help up, and it's going to be a lift assist / patient refusal. So prior to arrival, that's the kind of call that I was expecting. So we arrived on scene, and the patient's wife showed us to the laundry room, and the laundry room is this kind of like narrow corridor with two appliances on the left with a countertop over top of them, and the patient's sitting semi-upright, kind of guarding their left side like this, with some facial grimacing. They looked in pretty significant distress, and I noticed kind of right away this big contusion on his upper right forehead, and it was about a 3-inch diameter purple center with about a 1/2-inch ring of yellow around it. And just to dive into the pathophysiology of contusions a little bit, a contusion occurs when there's damage to the skin, usually caused by trauma, such as an impact or a blow to the affected area. And what ends up happening is the blood vessels underneath the skin get damaged, and oxygenated blood ends up pooling underneath. And that's what gives rise to the kind of red-purple discoloration that you'll see in the swelling. Eventually, though, the blood becomes deoxygenated after about 2 to 5 days, and hemoglobin starts breaking down into a pigment called biliverdin. And that gives rise to a kind of bluish, dark purple color. And eventually, the hemoglobin breaks down further, the bruise will turn into a greenish color, and then the biliverdin will break down into another pigment called bilirubin. And that will give rise to kind of a yellowish color. And that happens after about 7 to 10 days. And eventually, the pigments get reabsorbed by the body, and the bruise will fade. But this bruise, presenting with the purple center and the yellow ring, I knew that it didn't happen from today's event. So I continued with my assessment, and I introduced myself while my partner set up the cardiac monitor, and I kind of asked him what was going on, and his airway was patent, he was alert and oriented, but it kind of hurt him to speak, so I didn't want to continue questioning him too hard. I did notice that his breathing was a little bit shallow and irregular, and it just looked like it kind of hurt him to breathe. I auscultated his lungs, and I did notice some minor wheezing. It wasn't like audible to the naked ear. His circulation was tachycardic. It was full and regular, but I could tell that it was quick. So I palpated the back of his neck, and when I did that and I asked him if it hurt, he was kind of like, yeah, that hurts. So I had my other partner go and grab the C-collar and have that applied while I continued with my assessment. And interestingly, I noticed that when I was checking his pupils with my pen light, his pupils were a bit sluggish to respond to the light. They were equal and they had normal dilation though, so I kind of moved on. And at this point, the cardiac monitor was applied, and they were hypoxic, they were hypotensive, they were tachycardic, they had it all. They were SpO2 of 89%, 84/49, and about 110 was the heart rate. So I got a little bit concerned for this patient, so I had my partner go and grab the scoop so that we can extricate the patient as quick as we could. I continued with my assessment. The clavicles were stable, but they were a bit tender, especially on the left side. The intercostal margins were tender, and I did notice some instability on the left side. When I exposed the chest and abdomen, I noticed right away this rather large, about 4-inch in diameter hematoma on the upper right quadrant of their abdomen. And it was kind of distended in the center, and when I palpated it, it was rigid. The pelvis and femurs, they were unremarkable, they were stable. This patient, he was diaphoretic and he was pale, and I did notice that on his pedal extremities that there was some peripheral edema present, and when I palpated that, it was pitting. The back, they had another contusion on their right scapula, and it was about this like diagonal 5-inch contusion that was about maybe 3 or 4 inches wide. And when I palpated their spine, it was a bit tender, but there was no instability or crepitus. So we wanted to extricate the patient, so we got him in the scoop, and we were eventually able to get him into the ambulance. And we reconfirmed with a manual blood pressure assessment that they were hypotensive. So we inserted a 20 gauge IV into their right AC, and we initiated fluid bolus. And I had my partner set up 4 liters of oxygen through a nasal cannula while I assessed their pedal CSM. And the capillary refill was slow, but they retained motor and sensory functionality, which was good to see. So we initiated transport fairly quickly after that, we ran a CTAS-2 code 4. And to understand the severity of this patient, I'll talk about the pathophysiology in a second, but just to recap all of the abnormal findings that we had a contusion on the upper right forehead, contusion to the right scapula, unstable intercostal margins, peripheral edema, diaphoresis, minor wheezing, possible neurological compromise due to their slow papillary response, and we have hemodynamic instability with their hypoxia, their tachycardia, and their hypotension. The hemodynamic instability was especially concerning because this patient's vital signs were consistent with decompensatory stage of shock. So to further investigate this, I took a temperature reading, and the tympanic reading came back with mild hypothermia of 35.1 degrees Celsius. So we brought the patient to the hospital, and I gave my triage report, and they ended up taking the patient in right away. No surprises there. But later that day, we brought in another patient, and I went on a hunt for that nurse, and I asked her about that trauma patient. And he ended up having 6 fractured ribs along his left side and a slow bleeding subdural hematoma. And he was currently waiting transfer to a trauma center via Orange. So that kind of struck me a little bit, and I ended up learning a lot from that call. Because while I was definitely concerned about the patient and I wanted to initiate transport quickly, I didn't fully conceptualize the gravity of the situation as deeply as I think I could have. I was sort of following the procedure that I was taught in school and working through my assessment and treatment in a sort of trance. It wasn't until after the call that I was able to kind of debrief and fully grasp how every one of my findings kind of came together to bring clues as to what was really going on. For example, I noticed that the patient's pupillary response was sluggish when I was assessing with the pen light, but with the GCS of 15, the equal and normal dilation of the pupils, and the other traumatic injuries, I wasn't really focused on that particular finding. However, if I was able to better connect the dots in the moment with respect to their hemodynamic instability, the contusion on their head, and the sluggish pupils, I might have had more concern for something like intracranial pressure, and I would have paid better attention to their neurological condition, and I would have looked at their breathing patterns and made sure that it didn't progress into something like Biot's respirations or ataxic respirations, as I did note that they kind of had irregular breathing on initial assessment. And I thought that that might have been due to their rib fractures, and while it probably was, it's still important to look at the patient's overall presentation. And during my triage report, it would have been pertinent information to address the concern for their head injury and point my findings in such a way that point toward that as a concern to ensure that it gets addressed as quickly as possible. Instead, my main concern during the triage report was the abdominal hematoma and the rib fractures, as I thought that they might have been internally bleeding from their abdomen. Luckily, the hospital staff are professionals and they caught the subdural hematoma regardless.